Good evening, everyone, and greetings to all the delegates who have joined for this lecture. This lecture is part of our Amrita International Lecture Series 2025 as part of our department's Silver Jubilee celebrations. I am Dr. Shanmuga Sundaram, and I take extreme pleasure in welcoming our chief speaker today, Dr. Townsend, who doesn't actually need any introduction, but we will definitely be introducing him. But before that, some of the delegates who have joined for our lecture series for the first time, I like to highlight the importance of this lecture series. This is part of our department Silver Jubilee celebrations academic activities. And our department started in January 2000 with a single dual head gamma camera, has evolved over the last 25 years today. And now we are performing more than 1,500 procedures per month. We are equipped with two gamma cameras, one SPECT CT, one PET CT, one PET MRI also. We provide all the therapeutic and diagnostic services in nuclear medicine for this part of the world. And we are also running a nuclear medicine training program, MD Nuclear Medicine. This year, as part of our academic celebrations, we have introduced two fellowships in nuclear oncology and theranostics, one for Indian student and also another for an international student. We are also looking forward for starting the BSc Nuclear Medicine program. We are just waiting for the AERB clearance for that. Uh, I have extreme pleasure in now in introducing our chief lecturer, Dr. David Townsend. Dr. David Townsend obtained his BSc degree in physics from Bristol University, and he also did his PhD in particle physics from the University of London. He was a staff member for 8 years at the European Center for Nuclear Research in Geneva, Switzerland. In 1980, Dr. Townsend joined the faculty of Geneva University Hospital as a physicist in the Department of Nuclear Medicine. He has worked on PET instrumentation development since the early 80s and designed and built the first rotating partial ring PET scanner using BGO detectors. In 1993, Dr. Townsend moved to the University of Pittsburgh as an associate professor of radiology and senior PET physicist. He was the co-director of the Pittsburgh PET facility from 96 to 2002, and he became the professor of radiology in 2000. In 1995, Dr. Townsend was the principal investigator on the first proposal to design and build a combined PET-CT scanner. The PET-CT scanner, attributed to Dr. Townsend and Dr. Ronald Nutt, then the president of CPS Innovations, was named by Time magazine as Medical Invention of the Year 2000. In recognition of his work on PET-CT, Dr. Townsend received the 2004 Distinguished Clinical Scientist Award from the Academy of Molecular Imaging and the 2008 Nuclear Medicine Pioneer Award from the Austrian Society of Nuclear Medicine. In 2006, he was elected as a fellow of IEEE, and also in 2009, he received an honorary doctorate from the University of Mediterranean, France. He shared with Dr. Nutt in 2010 IEEE Medal for Innovation in Healthcare Technology, and from 2003 February to 2009, Dr. Townsend was the Professor of Medicine and Radiology and Director of Molecular Imaging and Transitional Research Program at the University of Tennessee. In July 2009, he became the head of PET and SPECT development for the Singapore Bioimaging Consortium. and he also was the professor of radiology at the National University of Singapore. He was also appointed as the director of the A-Star NUS Clinical Imaging Research Center in Singapore in 2010. In 2012, Dr. Townsend was elected as a honorary fellow of UK Royal College of Radiologists, and he also received the Vikram Sarabhai Distinguished Oration Award from the Indian Society of Nuclear Medicine in 2016. In 2013, he was presented with the Koo Memorial Lecture in Singapore College of Radiologists. In July 2013, he received a honorary doctorate in science from the University of Bristol in UK. And in December 2013, he gave the 8th John Cameron Memorial Lecture in International Society of Medical Physicists meeting in Singapore. In 2014, Dr. Townsend was presented with MI Labs Advanced Imaging Scientist Award and in Netherlands. His current research areas include the application of hybrid imaging technology in oncology, and also he is particularly interested in the low radiation dose imaging. We have immense pleasure in inviting Dr. Townsend for this lectures, and we are really happy and thankful to Dr. Townsend to have him for this evening for this very much looked forward lecture. Dr. Townsend, I hand over the screen to you, and we are looking forward for a great lecture from you. Thank you, sir.
Okay, well, thank you very much, Dr. Sundaram. I hope everybody can hear me. Thank you for inviting me to present this lecture. In 2018, I actually retired from the directorship of the Clinical Imaging Research Center. So what I'm going to do today is kind of summarize the history of the development of PET-CT and its origins back at when I was working at the European Center for Nuclear Research, CERN, in Geneva. It's particularly fitting that your department was initiated in 2000, so you are celebrating 25 years of work and imaging. And what we're celebrating also this year is 25 years of PET-CT, a quarter of a century since the first PET-CT images were acquired on commercial machines. And I've titled this talk From Pioneer to Patient, and I will explain right at the end why I have my own experience with PET-CT as a patient. So the topics I'm going to cover are the early days at CERN, which Dr. Sundaram mentioned. I was working there in the 70s and then moved to the University Hospital of Geneva in 1980. And so I'll describe our developments at the University Hospital in Geneva during the 80s in collaboration with the Medical Research Council in Hammersmith Hospital in London. And then I'd get to the birth of the PET-CT, which was developed while I was a faculty member at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. Give a couple of slides on the PET-CT in general clinical practice, but of course many of you are involved in that and will know probably more about it than I do. And then a few words on the PET-CT and the future, and where I think obviously it's going to play an important role in theranostics, which has actually become significant especially since I retired in 2018. So I don't have any direct experience of using PET-CT in theranostics, but I will summarize a couple of slides. So let's begin at the beginning, which was the early days in CERN. Now, the benefits of being at CERN was that you work with very high performance imaging equipment that is used to image particles. And a lot of the components are very similar to the ones that we use in medical imaging. So we have detectors, we have readout electronics, we have triggers which specify what type of events we're going to acquire. In the case of particle physics, it's triggered obviously by certain types of particle. In the case of nuclear medicine imaging, it's obviously triggered by in the case of PET imaging, by coincidence events. And in both cases, there are background events such as randoms and scatter, which have to be removed from the data in order to visualize the signal. We both have demands on data storage and on obviously processing the data, analyzing the data, and then image display and review. So in many ways, there are a lot of similarities, even though, of course, the data rates for the physics experiments are very different from the data rates for the medical imaging. And the triggers in particle physics are very specific. So the acquired data rates are actually much lower than they are in medical imaging. But it's certainly an environment in which the development of detectors is very, very important. Now, in positron emission tomography, as you all know, you radio label a physiological molecule, such as glucose, with a neutron deficient positron emitting nuclide, such as fluorine 18. And then you have a pair of detectors operating in coincidence. The fluorine 18, which is neutron deficient, wants to convert protons in the nucleus into neutrons in order to become more stable, resulting in the emission of an electron, a positron, which then annihilates in the tissue after a certain path with a free electron in the tissue, giving rise to two back-to-back, approximately back-to-back gamma rays. And that's how you're able to follow, to trace where the glucose molecule goes after you inject this compound, the radio-labeled glucose molecule, in this case, into the patient's circulation. You can then follow which organs capture the glucose, and you're all very well aware of typical FDG images. That's a typical FDG image of the human brain. And this technique is known as tracer technique. It was developed back in the 40s by George de Hevesy, who obtained the Nobel Prize in Chemistry in 1943 for this technique. So this is the tracer technique, which is fundamental to all nuclear medicine imaging situations. Now, working at CERN, you have the capability of developing many high performance imaging instruments. And when I was involved at CERN, I was introduced to the idea of imaging 511 keV photons from PET. It's not obviously the mainstream activity of CERN, which is a laboratory for high energy physics. But we did have access to a lot of high performance computing and imaging equipment that was not in those days available typically in hospitals or research laboratories. But it's really important that you have a good collaboration between the science side of things and the physician, because otherwise there's a tendency to solve problems that are really not the problems that need to be solved, say in the medical arena. So there was always a tendency to come up with solutions for what you thought was the clinical problem, when in fact it was not really going to work on the clinical side because that wasn't the problem. So the first thing was to establish good collaboration with the local clinical establishment, which was the hospital, the University Hospital in Geneva. And in fact, in 1980, I moved from CERN to the University Hospital in Geneva. But what we had developed prior to that was a little prototype. And to look at it now in the top right-hand side of the screen, to look at this instrument now, it's hard to believe that we were actually able to install it in a hospital and image patients. The development came from the invention of the multi-wire proportional chamber in 1968 by George Sharpak, who obtained the 1992 Nobel Prize in Physics for his invention. We took that, and under the direction of Dr. Alan Jevons, seen here on the right-hand side, we converted the multi-wire proportional chamber that was used for imaging particles, charged particles. We converted it into a device that would image 511 keV photons. And this little prototype device, which we developed at CERN, so here we are in the laboratory at CERN, was ultimately installed, as you can see here in the bottom right, at the University Hospital on a rotating gantry. So we had a device that could image in different positions, and then we rotated it on this gantry so we could acquire a fully 3D data set. And Dr. Alan Jevons was the inventor of this device, and Professor Alfred Donat was the head of nuclear medicine at the University Hospital in Geneva, who hosted this device. And ultimately, I moved to the Department of Nuclear Medicine in order to work more fully on medical imaging instrumentation as opposed to instrumentation for particle physics. And so when we had this little device at CERN, we wanted to take some images of something that would be useful, something that would convince people that it was a good device for imaging physiological systems, such as patients. And we went to Marilena Straight-Bianchi, who was a person who was working she's a radiobiologist working on radiation dosimetry to human tissues, obviously a very important topic to be studied at CERN, where radiation levels were very high. And it was very interesting to know what would happen to radiation doses to biological tissues. So we went to her, and she was able to inject fluorine-18 into a small mouse. And so we imaged back in 1977, the first image shown here in the bottom left of the bone structure of a mouse. And you can see how crude it is compared to modern day imaging, but it was a fundamental step to demonstrate that our instrument had the capability to image some physiological system, in this case, a mouse. And CERN made a poster of this work in 1977. So although looking at it now, it's very crude, it was a fundamental step to the development of subsequent instrumentation. Then in 1980, I moved from the European Centre for Nuclear Research to the Hospital of the University of Geneva, and eventually set up a collaboration with the Medical Research Council at the Hammersmith Hospital in London. And we built a more advanced version of this system, which is called the HIDAC, the high density avalanche detectors. And here you see it at the University Hospital in the early 80s in Geneva, with detector electronics that came from CERN that was used for detecting particles. It was called CAMAC in those days. And here you see the two detectors that are rotating around the patient lying there on the bed. And we obtained iodine-124 from Manchester, the Nuffield cyclotron at Manchester, and imaged the thyroid gland with I-124, and started presenting our results of this small, what was high-resolution imaging here at the Medical Radionuclide Imaging Meeting in Heidelberg in 1980. And this is Mike Phelps, who's attributed as one of the inventors of the entire PET technology field. Myself, Alan Jevons, Ed Hoffman, who was a physicist working with Mike Phelps and developed some of the very first medical imaging instrumentation for PET. And here I am with Professor Alfred Donat in 1988, appeared in a newspaper, and in Geneva, here's our little prototype rotating system. And this is the team that we set up. Dr. Frey was a nuclear medicine physician. Dr. Tochon was a radiochemist. Professor Donat, Anne Christin was a technologist, myself, and Antoine Geisbuehler, who was a medical student with a particular interest in computing. And he developed a lot of the computing algorithms that we needed to reconstruct the data from this HIDAC, high-density avalanche chamber positron camera that we installed at the University Hospital of Geneva in the early 1980s. And Antoine is still in Geneva, and he's now dean of the medical school in Geneva. So he began with us, and now he's a very important and high-level physician working at the university, still working at the University Hospital in Geneva. In order to reconstruct the data from our small HIDAC system, we needed to develop 3D reconstruction. And this, with collaborators such as Rolf Clack-Doyle and Benno Shaw at CERN, we started to develop some 3D reconstruction algorithms that would enable us to take the data from the small HIDAC system and reconstruct it into full three-dimensional images. And I show three images, three photos here of the computer technology that we had available. This is the old CERN CDC 7600, which was their mainframe technology back in the 1980s. We worked on digital equipment, devices, and of course, eventually workstations started to appear. And many of you have probably not heard of the Apollo workstation, but this was one of the very first workstations that appeared in the 1980s. And of course, the power of this device is much less than what you have in your cell phone these days. So some historical slides of this of the computing technology that was available at CERN and at the University Hospital in Geneva. One of my mentors and one of the great PET physicists is Dr. Terry Jones, who was based at the Medical Research Council, Hammersmith Hospital in London, for pretty much his entire career. And Hammersmith was noted as the first hospital in the United Kingdom to obtain PET and start imaging with PET radioisotopes. It had a particular advantage in that in the 1950s and 60s, it had installed a small cyclotron. So one of the first medical institutions in the world to install a cyclotron. So it had availability to short-lived radionuclides. So even in the early 1980s, they were able to image blood flow in a foot, as you can see here, albeit a rather crude image, using CO2, where the O2 was oxygen 15, so a positron emitter. So this is a very early pioneering work from Hammersmith Hospital. And here you see us with Terry Jones, myself, and Alan Jevons in 1981. Since these detectors, which were built at the Rutherford Laboratory in England, performed in a similar way to our HIDAC. So we had this in common in that we could image using these types of detectors. We could image positron emitters. And so we established this collaboration through our early HIDAC work with Terry Jones in Hammersmith. And they were one of the very early adopters because of the cyclotron availability of radionuclides. They were one of the very early adopters of CTI's ECAT scanner. CTI was a company based in Knoxville, Tennessee. It was one of the world's very first developers of PET instrumentation and scanners. It was created in 1984, and in 1988 they shipped this scanner, the ECAT 931, to Hammersmith. So we were then able to do some real PET imaging on this device in 1987, sorry, at Hammersmith Hospital. And so I became involved with some of this work at Hammersmith Hospital. And the first step in this pioneering work was that these devices, these scanners like the ECAT, were shipped from CTI in Knoxville, Tennessee, and they imaged basically two-dimensional slices, because between each ring of detectors, and the detector now is bismuth germanate, the original PET scintillator. The PET detectors, each ring of PET detectors is shielded from the adjacent ring with what is called a lead scepter. So it's basically it's an annulus of lead around the ring that prevented anything other than these very small angle gammas from impacting the detectors. Obviously, PET is a three-dimensional imaging modality because once you inject it, the gamma rays are coming out in all directions. So it behoves us to try and take this device and image without scepter. So we could image fully in 3 dimensions with the scepter removed. And this, of course, would significantly increase the sensitivity of PET, because now you're capturing a whole range of different angles than you are in the way in which the device was shipped from the factory. And so it was really Terry Jones's idea to get rid of the scepter and image in 3D and increase the sensitivity of PET. And of course, this is now historic. All PET scanners now are fully three-dimensional. So no scepter was a big step in 1987 to improving the sensitivity of PET. And this is the work we did at Hammersmith Hospital. This is very early images of FDG in a normal volunteer in 2D and imaging in 3D. You can see, if you look closely, there are improvements in sensitivity as a result of imaging in 3D. And Michel de Vries, Antoine again, and Dale Bailey from Sydney were instrumental in pushing 3D imaging in PET. And this actually is the first fluorodopa scan 3D, taken in 3D in February of 1988. The main reason for putting the scepter in, you might ask why they were there, was one, there were no good 3D reconstruction algorithms, which is what we addressed. The other reason was that once you take the scepter out, you increase the scatter fraction of photons that are detected that scatter before they reach the detectors. But it was decided that even though the scatter fraction increased, it was preferable to image in 3D and simply correct for the scatter rather than try and physically limit the scatter by the insertion of scepter. And work at UCLA with Ed Hoffman and Simon Cherry, who's now well known for his work in total body imaging. They also started to push 3D imaging in PET. And this was one of the first papers we published in 1991 at the IEEE meeting on fully 3D reconstruction for PET camera. And the company, CTI, were visionary enough to develop a PET scanner with retractable scepter. So the scepter could be removed. So if you were worried about the scatter fraction, you could image with scepter. But if you wanted to image in full D, they physically were removed from the system. And so we had therefore now developed a detector system, a PET scanner with these block detectors, BGO block detectors that had been developed by CTI. So multi-rings of block detectors that could now image in 3D without the presence of a scepter. And this was basically a major step forward in increasing the sensitivity of PET. Then came the idea, well, if you now have much more sensitivity in PET, because we've taken away the scepter and imaged in 3D, thanks to the development of 3D algorithms, maybe you could remove some of the detectors, just have two banks of detectors, and rotate them, just like we did with the old HIDAC systems that we developed at CERN. And the advantage of this would be that you'd have a much more cost-effective PET scanner, because the major cost in the PET scanner were these block detectors, these BGO block detectors. And in fact, we then went as far as to build a scanner of this type. Here it is, installed at the University of Geneva Hospital, again, Professor Donat. And in May 1991, we acquired these FDG images of the human brain using this rotating system at the University Hospital in Geneva, and it was supported by research funding from the Swiss government. And we built this device and actually imaged a lot of patients using FDG, not just the brain, but also thoracic and abdominal. And it was a fairly successful development. And ultimately, 2 or 3 years later, it was commercialized by the company in Knoxville, Tennessee, CTI, as the ART, the Advanced Rotating Scanner, which was intended as a cost-effective entry into the PET imaging market. So if you wanted to get involved in PET imaging, you could look at this device, which was much less expensive than the full ring scanners. But of course, there were downsides. It was slower because you have to rotate the detectors in order to acquire all the full 3D data set. But apart from that, it essentially functioned and produced good FDG images, as shown in the top right. And we published a paper in the Journal of Nuclear Medicine on the rotating PET scanner using BGO block detectors. But it turned out that this was a key step in the development of the PET-CT, because this is what the device physically looked like with the cover removed. And you can see these gaps as shown in this schematic up here. You have these gaps between the detectors. And a oncology surgeon who saw this device, an oncology surgeon from Geneva, who we were collaborating with and taking PET images for him, he suggested, why not put CT in the gap? And then we get CT images, which he really understood. And these PET images, well, you get them too, but back in the 1990, PET was hardly known outside the research centers where it was being developed. So we thought about this idea, and this is the sort of schematic then we thought of: PET detectors and a X-ray source and X-ray detectors, which would then give you the possibility to image both structure from CT and function from PET. And so I was recruited by the University of Pittsburgh in 1993, and in 1994 we proposed to the National Institutes of Health to build a combined PET-CT scanner, and after a resubmission in 1995, we received a grant to go ahead and build the first combined PET-CT scanner. Just a little cartoon as to why you want to combine anatomy, structure, and function from PET. This is just a well-known painting from a Dutch painter. If I was to make it look more like a radiology image in black and white, so you have a very complex scene, as you do in the human body, and this is structure. Function, of course, as we knew, the functional images obtained by PET imaging did not have the high resolution of the structural images obtained by CT or MRI. So a similar image would look very blurred. But the power of functional imaging using radionuclides is that you inject a radionuclide that is very specific. And so the image you get is a rather sort of blurred image, a lower resolution image, but very specific. And we picked out this one character in the scene on the left as, say, the tumor or the pathology that you're trying to image. And so on the left, you have structure, on the right, you have function. So why not put the two together and have a high resolution structural image and a very specific functional distribution that's located exactly within the structural image. So then you have the best of both worlds. You have structure and function in one imaging system. And that was what was key about PET-CT. This is the team that we put together, two guys from Knoxville, Tennessee, from the factory at CTI. Thomas Bayer, who may be well known to you from the University of Vienna, who was my PhD student on the PET-CT, and Paul Kinahan, who was a physicist who joined me at the University of Pittsburgh. So the University of Pittsburgh obtained the grant, and we set about, in collaboration with CTI and also with Siemens, who had a joint venture with CTI, to build the first prototype PET-CT scanner beginning in 1995, and it took us 3 years. And it was under the leadership on the CTI side of Ron Nutt, who was the CEO of CTI PET Systems, which was the joint venture between Siemens and CTI. And this is the team under Ron, Raymond, Roddy, Tony Brunn, Larry Byers, and the engineers at CTI, and it was financially supported by the National Cancer Institute. And this is what the prototype looked like. And so we felt we built the first PET-CT device. As it turned out, it was not the first PET-CT device. So it's really the second PET-CT device. The first one, as we found out once we started presenting our work, was built by Dr. Sasaki at Gunma University in Japan, in collaboration with Hitachi, and it was built in 1983. But it was a different concept to combining the two. You had two separate scanners, PET and CT, and a bed that moved on rails between the two instruments. But it did allow you to acquire images that were aligned, structure and functional images that were accurately aligned, as long as the patient didn't move on the bed while the bed translated from one device to the other. So back in 1983, the team in Gunma University in Japan were actually producing PET-CT images, in this case, using O15 inhalation back in 1984, well before we even thought of the idea, but it was really little known outside Japan. So this is our prototype. We combined that rotating scanner, the ECAT ART, with a Siemens Somatome ARSP CT scanner. And here you see it. This is the design, the CT scanner in the front and the PET scanner in the back, mounted on a single gantry that rotated and allowed us to acquire data from both imaging technologies. And as Dr. Sundar mentioned, it was cited as the medical invention of the year in Time magazine in December 2000. So we took the first images, excuse me, at the University of Pittsburgh in 1998, and the prototype functioned for 3 years before we had to kind of put it away when it was replaced by a commercial instrument. And so these are some of the very early images of PET-CT, combined PET-CT taken in 1998. One patient study in particular convinced us we were doing something unique. This was a young woman with nasopharyngeal carcinoma that had spread to the lymph node. So on one side in this image, she had very high FDG uptake in an enlarged lymph node. So the CT was positive, the PET was positive, and the PET-CT didn't offer anything more. But on the other side, she had a very small lymph node that was negative on CT. Because it's very low uptake of FDG, it would have been read as negative on PET. But on PET-CT, seeing this FDG distributed around a lymph node convinced the physician that it was likely bilateral spread of disease, and she had a bilateral surgery that verified that this was actually a infected lymph node, a malignant lymph node. And so it completely changed the management of this patient because we had PET-CT. And this was an image from sometime in 1998. And this is the team: Ron Nutt, Thomas Beyer, Paul. Carolyn Meltzer was a clinical resident who was responsible for reading these studies. Marsh Martinelli was the technologist who ran the PET-CT, and that was the Time magazine article that appeared December the 4th, 2000, citing PET-CT as that invention of the year. So what I've summarized in the last half hour or so is the transition from our little HIDAC system developed at CERN and then installed in the hospital, then this rotating PET scanner that we developed with CTI, and then finally the PET-CT prototype that we developed with CTI and Siemens. And so it took 20 years from the first HIDAC in 79 to the first PET-CT prototype that was imaging in 1999. And you can see the number of citations of the key papers, and how the interest in PET-CT obviously far outweighed the earlier prototypes. But without these devices, we would not have been able to develop the PET-CT prototype. And that was a much cited paper on the very first combined PET-CT scanner with Thomas Beyer as the first author. But when we were proposing PET-CT, there were many reasons why we shouldn't do it. The device would be too expensive. Well, you know that it isn't because you have one yourself. That aligning PET and CT was only needed in 10% of the patients, but that's because software was being used and it only worked in 10% of the patients, mainly in the brain. Outside the brain, software completely failed to really to align accurately the imaging, any imaging below the neck. So it can't really be combined using software algorithms successfully, other than maybe for the brain. It was said that it was inefficient to tie up a fast CT scanner for a PET scanner, which in those days used to take 30 minutes or more. And that obviously has changed significantly. As you know, the PET imaging now is very much faster and much more in line with the time on the CT scanner. We were accused that the CT quality would be inferior to a full clinical CT with contrast. Well, that turned out not to be the case, because you can do CT, contrast CT, as part of the imaging algorithm. But the CT quality was identical to that you had in clinical CT scanners. There was a concern that PET scan patients would be then subjected to a high radiation dose CT, but of course, dosimetry in CT has progressed tremendously, such that very low dose CT imaging is now possible. But of course, a big concern was that you have a CT technologist or radiographer, you have a PET technologist or radiographer, and you'd require two of them to operate the combined scanner. Well, as you know, they're now dual certified, and you have a single radiographer. And probably the main criticism was, where would the PET CT go? Into radiology or into nuclear medicine? Because they're separate disciplines. But all that has been worked out now by having physicians board certified in both radiology and nuclear medicine. And so that ceased to be a hurdle to saying no to PET CT. So eventually, and it was not immediate, but eventually the medical community accepted PET CT. And so it turned out that once the commercial PET CTs became available in 2001, there was a very rapid adoption of PET CT over the years 2001 to 2005. By 2005, the main medical imaging companies were really not manufacturing PET-only systems. They were all being sold with CT. And so it was kind of an unusually rapid adoption of a type of imaging technology. When you bring in a technology that's disruptive, like PET CT, you typically get people, oh, this is wonderful, we can do so much with it, but then things don't quite work out, and you get, as you shown in the curve on the right, people get disillusioned with it because it doesn't perform like it promised, and then eventually it gets sorted out, and so it reaches a level which is maybe not as high as was originally expected. The PET CT was a little different because nobody really expected anything. And so when it was first developed, it really was only interesting to a small number of visionary physicians that felt this was the way to go. And then it gradually caught on over the years to reach a level of productivity that it has today, which is, of course, a very high level. It's a very significant instrument in imaging, medical imaging. And these are the first commercial designs. The left is the Siemens device. This is the GE device. And Philips came up with something a little different, which was to put a CT scanner here and then a PET scanner at the back, or PET in front and CT at the back. So they kind of kept the two things separate. But the fully integrated system was this one from Siemens. And even as early as 2006, 5 years after the first commercial instruments, there were publications in the Journal of Nuclear Medicine extolling the virtues of PET CT for imaging oncology. And so it was very rapidly adopted for the imaging of oncology. And you can see how the publications, so it first appeared back in the clinic 25 years ago, about here, and then the publications rapidly increased to the level where they are today. And there must be over 65,000 publications now in the literature on the use of PET-CT, primarily in cancer, but also in other applications, cardiac, shown here, and whole body imaging, looking for metastases. What happened was, over the years, from the first commercial instruments that were cumbersome to use and often difficult to get started, they became very high performance instruments. This is the Biograph Vision. GE also has its own PET-CT scanner. And this is kind of the state of the art in 2019. So then we'd had almost 20 years of PET-CT. You were covering an axial length of 26 centimeters, good sensitivity, small crystals, and time of flight, which I haven't talked about, but increasing the timing, improving the timing of these instruments was critical to eliminating some of the background activity. So you have very high quality images here in a few minutes, compared with the 30 minutes or more of the very first prototype design. And so, to finish, let me just talk a little bit about what has happened since then. In 2018, as you know, the total body PET concept became a reality. Terry Jones, a visionary in the field, back in 1990, had proposed this device, two detectors covering pretty much the whole body. And you can see they're panel detectors that you would rotate, similar to our HIDAC system, which is where Terry also began his PET imaging development. But of course, this was never built. It was never feasible. And then in 2018, Simon Cherry and the group at UC Davis came up with a total body PET imaging instrument that covered a meter or more of the human body. It was a huge development, but it was a total game changer in PET, because not only did you improve image quality, reduce the radiation dose, but you had the capability now of imaging the whole body in a single shot. So you could do dynamic total body imaging. And of course, with the imaging time being significantly reduced, you could improve patient throughput. And they actually realized this device in collaboration with United Imaging. So this is Simon, Ramzi Bazawi, and there's Terry, who drove our development of a rotating PET scanner and also drove this total body imaging development with Simon Cherry and the group at UC Davis. And you can see what you can do in 75 seconds imaging time with this total body. You get the whole body imaged in a minute or so. Much, much higher performance than we were used to back in the early days. And what this did was drive the development of a commercial total body PET-CT. In fact, the total body system that Simon had introduced also incorporated CT, because it was not thinkable to have a PET scanner that didn't incorporate CT, or as you know, also can be incorporated with MR. But now you had a commercial PET-CT scanner with a field of view of 106 centimeters, over a meter. So you could image pretty much the entire body in a single bed position, instead of stepping the patient through the instrument one bed position at a time. Very high sensitivity, small crystals, very good time of flight. And this is a couple of images from the University of Groningen in the Netherlands. So this is PET-CT, essentially PET-CT of today. This is the Biograph Vision Quadra, images taken in just 2-3 years ago. So this is the PET imaging capability. And recently Siemens have announced this. It's a new air-cooled system. It can be, it's not the total body system. It goes up to 24 centimeters, but it has good sensitivity and good time of flight resolution. And this is celebrating essentially 25 years of PET-CT. So this is where PET-CT has gone in the last 25 years. And you can see here these high-resolution PET images that one can acquire. This is acquired at the Royal North Shore Hospital in Sydney, Australia. And now there must be maybe more than 5,000 PET-CT scanners operational worldwide since the very first commercial system was installed in 2001. And of course, they're widely used now in theranostics, which has become the big development in the field of nuclear medicine, where you use the same physiological substrate, in this case for prostate with PSMA. You use it for diagnostics or diagnostic imaging labeled with a typical imaging agent, in this case gallium-68, a PET imaging agent, or you can label it with actinium-225, which is an alpha emitter. So when you diagnose, when the physiological substrate goes into the cancer of the prostate to be imaged, you can then inject very high levels of these short-range, high-energy deposition alpha emitters for therapy. And it's been dramatic. This is a PET, this is an image, initial image with the patient has a PSA of 246 using gallium-68, and then cycles of actinium PSMA that was taken up in these metastases, just like it was for imaging. But now the radionuclide is a therapy nuclide that destroys the metastases. So many, many examples now, and they're increasing all the time, of the capability of not only imaging disease, but also therapy, destroying disease in a very, very specific way, using very specific radionuclides. Now, the title of the talk was From PET-CT Pioneer to PET-CT Patient. And in the middle of last year, I had my own experience with PET-CT. I started to experience an unexplained sudden weight loss that didn't appear to be explained by a change of medication that I'd recently undergone. It was not considered to be consistent with that change in a type of medication I take. So I convinced my GP to send me for a CT scan, because that's what we have locally. And they discovered a suspicious left lobe lung lesion. It was a complete surprise. It was 2.1, it was about 2 centimeters in size. And I had a PET-CT then where the SUV, as you can see here, this is the tumor that I had in my upper left lobe, had an SUV of 2. So had I known that earlier, I would have probably not been so worried about it, except that a biopsy showed that it was an adenocarcinoma of the lung. So I was then faced with what to do about it, and I was sent to a very good surgeon, lung surgeon, who removed the upper lobe of my left lung, including the tumor, which was then analyzed to be found to be a grade 2. So it was not yet top grade. And It was unconnected to any of the respiratory structures. It was isolated in the upper part of the lung. It was a stage 1B because it was 2 centimeters. He removed it along with all 12 lymph nodes, and all lymph nodes were negative. So it looked like it was isolated and removed before it could spread, and therefore there was no further treatment. A 6-month CT that I had was normal, and when I changed back to my old medication, I reversed the weight loss. And this shows you, interestingly, this is my scan, my chest x-ray before surgery. They removed this entire upper left lobe. This is my chest x-ray post-surgery, and you can see how the lower lobe here has flipped up and extended into the cavity. So interestingly, the two images look pretty similar, even though I'm missing the upper lobe of my left lung. So the lesson here is that screening is essential to catch these early. Had I not done that, I would have probably presented in a year or so with stage 4, which is inoperable and pretty much untreatable. So I was actually very lucky that this change of medication got me to get some imaging done, and I was able to get very early treatment, and hopefully there'll be no recurrence, and that will be the end of that incident. And so finally, what we're celebrating this year is a quarter of a century of PET-CT, 25 years since the first commercial systems. A year or two earlier was the prototype. You can see here, this is the prototype PET-CT, operational in 1998. This is one of the images acquired just over 25 years ago. You can see movement artifacts, you can see liver artifacts because the liver is moving, the lungs are breathing, inflating. The CT quality is not so great. It took 4 positions of the bed to acquire this image. It took about 30 minutes of scanning time. There's no correction for any of the motion of cardiac, respiratory, liver movement. We use CT-based attenuation correction, some of the earlier algorithms, and we injected 10 millicuries of FDG. Here today you see a state-of-the-art instrument, this one from Siemens. I show that because Siemens was instrumental in this early development of PET-CT. Here is a state-of-the-art PET-CT scan. You see superb detail. You see no liver artifacts, no artifacts in the lungs, thanks to the motion correction, the very rapid imaging time. So here you're looking at just a minute or two of imaging to acquire more or less the whole body. So it's been tremendous development, tremendous improvement over the 25 years, as evidenced by these state-of-the-art instruments that exist now, compared with our little prototype system that we developed over 25 years ago. So that's the story of PET-CT. I apologize, it took a little bit longer than expected. I hope you learned something from how you begin a development that ultimately leads to something quite significant. And of course, I'm just the one giving the talk. Many other people listed here have contributed to this work back in the early days of the HIDAC system, all the way through to the prototype PET-CT scanner, and then the clinical applications of PET-CT later. And this has all been funded by research funding from the Swiss Science Council, from the US National Institutes of Health, and some of the clinical work in PET-CT was funded by the NMRC in Singapore, where I moved in 2009. And of course, I would like to thank you all for your attention. And I hope that this lecture gave you some insight into how PET-CT was initiated, developed, and has reached the level that it has today. Thank you very much for your attention.
Uh, Thank you very much, Dr. Townsend. It was an outstanding lecture and we learnt a lot. We also understood the painful path and the most difficult areas where you have gone through and your team in developing this, possibly we can say that instrument of the century as far as medical cancer diagnosis is concerned.
Thank you.
We really owe a lot the nuclear medicine physicians, our good position today in the society and in the medical fraternity, and also all the cancer patients. We all owe a lot to you and to your team. And we thought this awarding this lecture to you is a small contribution of our efforts and our ability to acknowledge your great contribution to the well-being of the patients, especially the cancer patients. Uh,
Thank you. Appreciate it.
we really owe a lot, sir. And I really thank you on behalf of our institute, our department, and also all the delegates for this excellent lecture. And I have taken the permission from you for putting up this lecture in the YouTube so that wider people can access this particular lecture. At this
Sure.
point, sir, I have collated some of the questions that I have got it through the chat box and also through the private WhatsApp to me. I will take the liberty of asking you some 4 or 5 questions, which I
Sure.
felt are most relevant to us. The first one is Dr. Zahir has put 2 questions. One is what were the skepticisms and what were the difficulties or resistance you had from the medical community in accepting this equipment initially? That is one of his question. And the next question is, what was the most transformative step or moment when you converted this prototype into a real equipment, from the concept to a real equipment? So these two I thought are a bit combined, so are a bit related. So I am putting up that question to you.
Okay, yes. So initially, I think the biggest issues we had was that we were working across 2 medical departments. You had radiology that was driving CT, MRI, X-ray equipment, and then nuclear medicine was the home of radionuclide imaging. And so when we decided to combine the two and started to talk about that, we were told that a big block to that would be that we were working across 2 medical disciplines. 25 years later, it may sound almost trivial and kind of not a good reason for objecting to this development. But medical departments can be very conservative, and it was not felt that such a device was necessary because it crossed 2 different departments, and it could in any case be done by software, and in most cases it wasn't necessary. Who needed CT and PET together? As usual, when you look back on these things, a lot of the reasons seem kind of a little far-fetched and hard to hard to justify now. But I can assure you that when I've presented at the Society of Nuclear Medicine meeting in Los Angeles in 1999, I think, some PET-CT images, a gentleman stood up after I'd presented the paper and said, "You may be able to combine the instruments, but you will never combine the departments. Your device will not be successful." And that's a true quote. from a large audience in 1999. Well, fortunately, the gentleman turned out to be wrong. And the visionary people like Rich Wall in the US and others that realized that adding structure to function was the way to go, they started to push it. It began in a few centers. Not everybody wanted to invest in PET-CT early, but because we had a few top physicians on board, the companies could then start to discuss a commercial PET-CT. Obviously, the prototype images were powerful. They were widely diffused, showing as many people as possible. And so a few physicians started to say at key institutions, this is the way to go. And I visited some of those institutions when we were attempting to promote the idea of PET-CT. And I think the vendors, GE and Siemens in particular, recognized that maybe they should invest in PET-CT. And this would have been in 1999, 2000. And the very first commercial PET-CT systems were therefore installed. I think one of the first was in Zurich, where Professor Gustav von Schultes was a big proponent of PET-CT. He worked with GE, and GE installed one of their very first PET-CTs in Zurich, Switzerland, in 2000, early 2001. And then Siemens installed their first system at the University of Pittsburgh in the summer of 2001. And Philips was a little bit slower to get on board with the concept, but they too started to come out with PET-CT within a few months. So it gradually got through to the wider medical community, but the early adopters were the ones that really pushed it. And as I said earlier in my talk, you have to get, if you're on the physics and engineering side, developing medical instrumentation, you have to get the physicians on board with what you're doing. You can't go around as a physicist promoting some sort of instrumentation to the medical community. You have to get the physicians on board. And this is what gradually happened in 2001, 2002, so that by 2005, the market for PET-only systems was very small indeed, and everybody wanted PET-CT. So it took about 3 to 4 years for that adoption to take place.
Thank you, sir. I am sure your point is very important, that the physicists worked together with the physicians to get this PET-CT up. And I am sure all critics must have eaten their words back within a very short period. So continuing with that same question, there are two sub things. One is what was the defining moment or the step in the integration of all your concepts as an equipment, and what was the most difficult step in integrating the PET and the CT when you developed this integrated PET-CT scanner?
Okay, so I guess when you remember I showed a picture of the concept showing the CT in the gaps between the PET detectors. It turned out that this was based on our concept, and I had never looked inside a CT scanner in my life. So when we did approach CT instrumentation people, they said, there's no way you're going to fit CT in those gaps, because there's a lot more to CT than just the X-ray tube and the detectors. You have cooling systems, you have all sorts of other parts of the equipment. So essentially, the complete ring of the CT is occupied by equipment. There's nowhere to put your PET detectors. So that was a big shock to us. kind of spoilt the concept. So we came up with the engineering team at CTI with an alternative concept, which was to actually attach to the back of the rotating CT gantry another, if you like, annulus of steel or whatever we were using, and then to mount the PET detectors on to this other flange that we'd bolted to the back of the CT. And this allowed us then to combine the PET and CT, not as shown in that schematic, but by putting the PET detectors on the back of the CT. And that was kind of the defining moment for us when we realized that we could combine the two. We still needed to interact fundamentally with the CT scanner to drive the bed through the entire imaging field, and that involved interaction with Siemens to be able to modify their CT code, which isn't something that is easy to access, but allowed us to move the bed from the PET console. And then we realized that we could actually build a combined system. When they started looking at things commercially, the decision was made not to go with the rotating PET detectors, but to actually take a full ring PET scanner and mount it behind the CT, as we had done, but not on the CT because it didn't need to rotate like the CT. So the vendors started looking at putting basically CT in front and PET behind as two separate, less integrated systems. And probably one of the most integrated PET CTs ever built was our prototype. And the vendors decided to go with combining the systems, but really keeping the PET and the CT apart. And this also allowed them to incorporate improvements in CT, say, into their PET CT scanners, and the same for PET. So it was a different approach. In fact, Philips came in with a completely separate PET and CT systems with a common bed. So the idea was then just to move the bed through two separate scanners, a bit like the Japanese, but by positioning the scanners one behind the other, you didn't have to move the bed sideways from one system to another. So those were kind of the defining moments in our development of the prototype, and then the subsequent translation into the commercial systems.
So does it mean that at no time a prototype was prepared with the partial ring detector and the integration of the CT in between? So it was, as you showed in the schematic diagram, it was never done.
No, that's right. I should have mentioned that, but it was never done because it's simply not possible to mount PET detectors on the same gantry in the front as the CT. So we mounted them essentially on the back of the CT gantry, but then they were then separate. They were in a different position axially. So you then had to do the CT first and then move the bed into the PET field of view.
Sir, at that point, did you have any problem in the computer data, so like hard disk, the overall quality of or there were not much of advancement in the computer system? So how did you manage that deficiency in as early as in 1990s and 2000s?
Basically, the computer systems were kept separate. So the CT was acquired from one gantry, and the PET was acquired, on one computer system and displayed on one display, and the PET was acquired on a different computer system and displayed on a separate display. And then software to merge and display the PET and the CT together started to be developed by the companies, so that you were then able to display PET and CT together rather than than side by side by assigning, say, a color scale to the PET image and the black and white to the CT. So you could then, and I showed some of those images, and you know what they look like from your own systems. You're able to display one image with both PET and CT visible on it. But the two computer systems doing the acquisition, even in the early commercial systems, tended to be separate.
Sir, do you have any experience or was there any contribution towards time of flight imaging during your integration of PET and CT, or was it a new technology after the integration?
Well, okay, so time of flight dates well before all this work. It's become much more well known now because you're actually you have the performance of the electronics in order to achieve 200 or 300 picoseconds timing. Time of flight was developed by two groups, Turpegoshen at Washington University in St. Louis, and a group in France at a laboratory in Grenoble. But this dates from the 80s, I think. But of course, they didn't have the time resolution that you have today. So the localization of where the annihilation took place was much less precise than you have with the 200 picosecond timing that you have today. I mean, their timing was in the nanosecond. So you had 7 or 8 centimeters of localization. But all this work was developed back in the 80s, 70s, and 80s on early research PET instruments. And then gradually, as the electronics improved, and CERN's work in timing has contributed a lot to that. Paul Lecoq, physicist at CERN, has been very instrumental in pushing time of flight in scintillator detectors. So once you then could achieve timing resolutions of a few hundred picoseconds, time of flight got revived because initially the scintillators that were fast didn't have the stopping power. So once you got to scintillators like LSO, which came out in late 1990s, you then had the timing and you had the electronics to go with the timing to achieve 200 picoseconds, which then allows you to localize the position of the positron annihilation to a centimeter or so. So then you can really implement time of flight and greatly improve image quality as a result of it. But I just want to stress this very early work was where the pioneering was done by Turpegoshen. And our first developments of PET-CT didn't really incorporate time of flight because there wasn't the timing there. The scintillator was LSO, but the timing electronics wasn't there. And so that was introduced into later versions of the PET-CT because you could incorporate developments in PET into PET-CT, just like you could incorporate like photon counting CT into the CT that's with the PET-CT scanner. So all these developments have been introduced into PET-CT as they've been developed for either PET or CT.
Thank you, sir. At any time during your journey of integration of PET and CT, did you think about integrating all three equipments, PET, CT, and MRI?
Not really. The PET-MR development came later. I was always asked, okay, so that's PET-CT, what about PET-MR? When I gave a talk during the late 1990s, 2000s. And I think the first commercial PET-MR system from Siemens was installed in the clinic in about 2010. So almost a decade after the first PET-CT. And it was really, that was a technological development of the PET detectors to allow them to function within a MR magnetic field. The I mean, obviously that development was something that was going on. I mean, even before PET-CT, there was some work in PET-MR because Simon Cherry and others used optical fibers to take the signal from the scintillator out to the phototubes that would not work in a magnetic field. And so some of the early fused images were actually PET-MR, not PET-CT. But the PET-CT development was less of a technologically demanding step than PET-MR. But we never really thought about incorporating all three modalities. I mean, we were aware that PET-MR was also interesting, but PET-CT was more straightforward and easier to use than PET-MR, although obviously PET-MR plays a huge role at centers that have PET-MR.
Sir, your final comments on possibility of developing cost-effective equipment. Countries like India really need more number of PET-CTs, and what are the best ways by which we can reduce the cost, or how to improve the cost effectiveness of the whole body PET-CTs? And is there a way of further reducing the cost of total body scanners?
Well, I guess I'm not really the best person to answer this question. I agree with you that one of the main aims should be a wider diffusion of this technology in places that do not have good access to it. As I tried to emphasize with my own example, had I not had access to that imaging technology, easy access, then the outcome could have been very different. Total body, or at least 1 meter field of view, is very useful for many applications, but I think it's more important to look at reducing the cost of basic PET-CT instrumentation so that it's more widely available. I'm not sure total body imaging needs to be as widely available because you have, that gives you capability of multi-organ dynamic imaging and so on. But basic, in my case, as I emphasized, just a basic CT scan gave notice that there was a problem. So, I didn't really need total body PET imaging to identify something that potentially saved my life. But good access to low-cost PET-CT scanners, for example, could transform the treatment of many, many diseases because they're found early. And while theranostics obviously plays an important role in targeted imaging of more advanced disease, early detection is still, I think, key to improving healthcare. What the companies can do to lower the cost of their instrumentation is not really something I'm qualified to answer. I've not been active in the field for the last few years, but I agree with you that it should be more widely available and more easy access to patients in order to diagnose diseases much earlier. So I'm sorry, I can't specifically point to areas that could be made lower cost. I mean, our attempt to make a low-cost scanner by rotating banks of detectors was a development, but very soon, once people realized how important PET was, they said, well, we just want the best instruments. We don't want this rotating thing that has lower sensitivity and takes longer to do the scan. We just want the best instrument. And so very, very soon after that, the company ceased to make it. So it's really important to try and get more cost-effective instrumentation, but people really want also the top performance in their instruments. So that's a question that would be best answered, I think, by somebody from industry.
Thank you, sir. One last thing, it is great to note that even though you are retired, even today you are still actively researching. So can you just tell very briefly what actually you are working today, and in what way we can expect some more help or some more new equipments from you for the betterment of the medical community?
Well, to some extent, I mean, I'm retired and I just keep in contact with the various groups. I'm not actively researching. I do work with a small company in North Carolina that's developing instrumentation to detect extravasations when the radiation dose is not properly injected, either for imaging or for or for treatment. I mean, I am going to Siemens in a week, so I'll be more updated on what they're doing. But I've kept a lot of interest in the field, but I'm not sort of actively researching areas, so I'm not sure. Not sure that I can really tell you any more than that.
Thank you very much, sir. We are really proud to have you today. And I think once again, our sincere thanks to you. And we owe a lot to you for the betterment of the whatever you have done for the betterment of these patients of cancers, and also for the Nuclear Medicine Society. At this point, on behalf of all the delegates and on behalf of our institute and department, I thank you profusely, and also we wish you a good health future, and there should not be any more issues to you. Thank you very much, sir. And we once again we are really privileged to have you in our
Okay, well, thank you. Thank you very much indeed for inviting me. I hope my lecture was useful and interesting,
Thank you, sir.
and I greatly appreciate hearing from you and to have been able to do this.
Thank you very much.
Thank you very much indeed. Thank you. Bye-bye.
So with this, we come to the conclusion of our fourth lecture. Thank you all delegates. Thank you very much.